This PowerPoint, we're going to talk about CPAP titrations and the protocol we'll use, and then we're just going to touch on bilevel PAP therapy and some side effects and conclusions. CPAP, how it works. CPAP stands for Continuous Positive Airway Pressure. This is applying room air, not oxygen, there's no oxygen involved, into a continuous stream which opens the upper airway, allowing the patient to breathe without interruption. CPAP is measured in centimeters of water pressure. The pressure ranges typically used are anywhere from 4 centimeters of water pressure to 20 centimeters of water pressure. We wouldn't want to go below 4 centimeters of water pressure, as the patient might feel like they're suffocating because that's just not enough. Now, a lot of times people refer to flow, and that's in regards to oxygen therapy. CPAP is completely different than oxygen therapy. Oxygen is a drug. It is an increasing amount compared to what is in our atmosphere when we use oxygen therapy, and we're just talking about positive airway pressure. So this is just the flow of regular room air pushing the airway open. CPAP pressure is then titrated to correct the patient's respiratory disturbances. It acts as a pneumatic splint to help open the airway. That's an important term you're going to see again and again, is a pneumatic splint. CPAP needs to be titrated, meaning adjusted, to find the patient's lowest setting that treats their sleep-disordered breathing. So you don't need to know all the ins and outs of how a CPAP machine works, but you should know that it is comprised of a circuit board. That's the digital component that really runs the machine. It sets the pressure and adjusts the pressure. There's a fan-driven, turbine-driven air blower, and this is what actually creates the positive pressure. So imagine it's like a fan where the air coming out of the fan is enclosed into a tube. So the top picture, that's the circuit board. The next picture down, that's just the fan sitting in the base of the machine, and then the bottom picture is what the blower looks like. That's it. There's no oxygen, nothing. Again, just going on with how it works, these machines are powered by electricity, so you need some type of electrical source. It typically plugs into regular wall outlets. It can get adapters to be used in a car or a motorhome. There's some other battery adapters that you can find as well. The pressure ranges on these machines is from 2 to 20, but therapeutically, as I mentioned before, we want to use a pressure of at least 4. Rarely do you see anything go above 20, but in some circumstances, some machines can go up as high as 30, and some patients do need more than the 20. But those are pretty rare instances. Rebreathing of a person's own exhaled air is prevented by having a vent or a valve, which is included in the interface device. An interface device is the actual mask or nasal prongs or nasal tubes that actually connect the device to the patient. There has to be a nice seal. No pressure can be leaking out of the device, otherwise it's not going to be effective to treat the sleep apnea. And so since the patient is breathing in and out into a small mask or nasal prongs, you need some type of a vent so they don't rebreathe their own air and cause them to have too much CO2. So usually the vent or a valve is built into that interface device, whichever device you use. So how CPAP works? Well, on the left you have a picture of a patient sleeping without a CPAP on. The first picture on the top, you see a normal breathing patient. They are breathing effectively. The blue line represents air entering the airway, and you can see it's identifying where the tongue is the uvula. That's that little thing that hangs down in the back of your throat, and then also your soft palate. The picture in the middle, going top to bottom, this person is snoring, and you can see the blue line it can't go through the airway as easily as it does on the normal breathing patient above that. This is a partial airway obstruction, and it's actually vibrating as the patient tries to breathe at night. This uvula and the soft palate is actually vibrating around, which actually causes those tissues to become more inflamed and edematous, which then worsens the sleep apnea. The bottom picture is a person who has complete obstruction of their airway when they're sleeping. You can see the blue line, no air can get through at all. When this happens, the patient continues to try and get air in by their respiratory muscles, try to suck and work to try and open that airway. Eventually, the airway does open, typically due to an arousal because the patient's CO2 levels have gotten too high or their oxygen has gotten too low, and the patient wakes up, their airway opens, and they resume breathing. They're not fully awake, but just enough to use those muscles and open the airway again. So how CPAP works is your picture on your right. You can kind of see a little shade of a mask covering the patient's nose, and the blue kind of thicker line going down the airway. That is representing the air pressure. So with the CPAP mask or interface device on, the air pressure is delivered into the patient's airway, and it pushes that soft palate and uvula out of the way so air can get down into the lungs and the patient can breathe in and out freely. So it is a pneumatic splint that holds the airway open during sleep. Initiating therapy, just touching on this, it's always best to have the patient try a few different styles of interface devices and have them select what they are most comfortable with. One important thing is if a patient cannot breathe through their nose or one nostril, then they're not going to be able to tolerate a nasal mask, probably. So that is a good rule of thumb, to have them pinch off one side of their nose and see if they can breathe freely through the other side. Once the patient selects an interface device and you have provided education on what the CPAP is going to do, how it's going to help them, how it works, then you want to give the patient some time to habituate themselves to the device or desensitize the patient to the device. This involves letting them hold the mask on their face at first without any pressure, let them feel what it'll feel like, then add the pressure to it, plug it into the machine, turn it on, have them hold the device over their nose and mouth, whichever type of device they're using. Again, it has to have a nice seal so you can't have air leaking out from it. And by them holding it, they have control to take it off their face when they need. Once they're comfortable, attach the headgear to it and have them put it on and allow them to sit quietly, read, or watch some TV just to get used to the sensation and adapt their breathing to how it's going to feel. This is not normal for people, so everyone maybe will take a little bit of time to get a little comfortable and be ready to close their eyes and try to sleep. Our titration goals is to get the lowest possible pressure, which treats the patient's respiratory disturbance during sleep. You want to ensure that the patient can tolerate the treatment and feels comfortable, so that the comfort of the mask, the humidification of the air, are all important to getting the patient used to the device and comfortable. You want the patient to have less than 5 respiratory events per hour of sleep. That includes apneas and hypopneas. You want them to have an SpO2 of 90% or greater during sleep. You want to eliminate as many EEG arousals and RERAs as possible, preferably below 5 per hour of sleep. And again, you want to eliminate snoring. And this has to be in the patient's supine position as well as in REM sleep. And again, you want the lowest pressure possible. So to do a titration, we usually start low. The slide says 3 centimeters of water pressure. That actually is not the recommendation. 4 centimeters of water pressure to 5 centimeters of water pressure is the recommended starting pressure by the AASM. So 4 to 5 is what you want to know. You're not going to increase the pressure while the patient is awake. You wait till the patient falls asleep, and then you're going to increase the pressure by 1 to 2 centimeters of water pressure until snoring is eliminated and respiratory disturbances are minimized. Some notes about this. Again, you want to find the lowest possible titration pressure for the patient. If you have too low of a level, it will not control or have any effect on the respiratory events. If you have levels that are too high, it can actually cause more side effects, increase patient discomfort. It can actually induce a different type of respiratory event. And then again, you want to get the lowest level of pressure when the patient is in REM and sleeping supine, treating all respiratory events and maintaining a good oxygen saturation. Okay, so here's the actual protocol by the AASM. Now, each sleep center that you might be at might have a slightly different protocol, but I guarantee their protocol is going to still fit within these guidelines. This is a pretty aggressive protocol in my opinion. So if you want to take a look, you're going to start down at the bottom left-hand corner where it says minimum starting pressure, 4 centimeters of water pressure. That is lights out with the device on, and after 5 minutes of time, when the patient is asleep, if you see 2 obstructive apneas, 3 or more hypopneas, 5 or more reras, or 3 minutes of loud or unambiguous snoring, then you can increase your CPAP pressure by 1 to 2 centimeters of water pressure. Once you've increased your pressure, you need 5 more minutes of sleep, and then you need to again see either 2 obstructive apneas, 3 hypopneas, 5 or more reras, or 3 or more minutes of loud, unambiguous snoring before you can make another CPAP pressure change. Now notice, if the patient awakens and complains that the pressure is too high, decrease the pressure so the patient's comfortable, allow them to return to sleep, and then you can resume your titration. If you go 30 minutes without any breathing events, then you can do an exploration of pressure. That means where you go up a little bit higher pressure, 1 to 2, see how they do there. Sometimes it might look like you have the good pressure, but they still haven't been in REM yet. So if you increase it a couple more centimeters of water pressure, you might see them go into REM. Again, you need to see the patient in supine and REM sleep at your pressure that you think is treating their sleep event or respiratory events before you can consider that you have found the correct pressure. If the patient starts developing central sleep apneas or really long hypopneas, then you want to decrease your pressure and see if that resolves. So sometimes that is what we call over-titration, where you've gotten too high of a pressure. So this is the basic protocol that you want to have committed to memory and that you will use when you're scoring your respiratory events. BiPAP. So BiPAP uses 2 levels of pressure. An IPAP, or inspiratory pressure, and an EPAP, which is your expiratory pressure. We refer to BiPAP settings as IPAP over EPAP. The difference between the 2 set pressures is generally expected to be at least 4 centimeters of water pressure. Again, anything lower than that is not going to be effective, but if you get anything too high, then the patient's not going to have restful sleep. We're just going to touch on BiPAP in this unit because next quarter we're going to come back and spend more time on BiPAP as well as the titration protocols for it. So with BiPAP we have 3 different modes. We have a spontaneous mode, and this is where it automatically detects changes in the patient's breathing and the machine itself shifts from IPAP to EPAP. We have a timed mode. This is used for patients who have severe breathing abnormalities. It switches from IPAP to EPAP based on a time factor, meaning we have a set respiratory rate. We have a spontaneous with a timed backup mode, and this is our most commonly used mode. And this is auto detection, but it includes the safety of a timed backup just in case the patient fails to breathe on their own. BiPAP treatment is typically used for central apneas. Increase patient compliance when their pressure levels are too high. BiPAP allows for that lower pressure on exhalation, which some patients find more comfortable when they have extremely high pressures to treat their sleep apnea. Most labs, I should say all labs, begin with CPAP before switching to BiPAP. The reason for this is insurance has very strict guidelines in approving BiPAP for reimbursement, and so the patient must fail CPAP first before BiPAP can be tried. So you're always going to start with CPAP first, and before switching to BiPAP you want to make sure that that is approved by your facility's protocol. Okay, PAP side effects overall. This is any type of PAP therapy or positive airway pressure therapy. Air leaks. This can cause dry eyes. You want to avoid air leaking into the eyes because it can damage their cornea. Dry mouth, nasal congestion and dryness, claustrophobia, skin rashes, and partner intolerances. These are all common side effects, and you as the sleep tech are going to try to help your patient overcome any of these. And you're going to want to check with your patient and make sure if they are experiencing any of these to let you know so you can help them have a more comfortable experience. CPAP compliance is one of the biggest hurdles to treating respiratory disturbances. Here are some tips the technician can use as a front line in the patient success. Provide patient education, not only before starting a titration, not only before starting a sleep study or before your patient leaves, but also offer them some support groups, materials, websites and the sleep lab and staff as a resource when they need questions answered or want some help. Educate the bed partner as well as the patient. Make sure that you have proper mask fitting and that the patient is comfortable with their interface device. Make sure the patient has had significant time for desensitization, and involve the patient in all of the decision making about their PAP. Oxygen administration. Occasionally supplemental oxygen will need to be given to patients even after the optimal PAP levels are reached. But first you have to titrate the PAP therapy to where the respiratory events are eliminated. Even if the patient's desatting and having low oxygen saturations, you cannot add oxygen to that patient until you have found the proper PAP level to eliminate all respiratory events. So oxygen is the very last thing you're going to do with these patients. Oxygen is typically given when the respiratory disturbance events are corrected, but oxygen saturation levels continue to fall. Oxygen does not treat sleep apnea, it only treats hypoxia. Oxygen tubing in the critical care environment or acute care setting is usually delivered via a nasal cannula and tubing. When we're using it in accordance with our PAP therapy, you will actually put it in line closest to the machine to ensure proper delivery to your patient. You always want to document everything, especially when you're adding oxygen to your patient. And make sure you are verifying with the medical director if needed, and never practice this outside of your sleep center's protocols. This concludes this PowerPoint.